Just whilst that's happening, do you guys want to like put your hand up if you have done anaesthetics before, just so I know like roughly, as in if you've had the placement, basically. Okay. Cool. Okay, so can I take control, Anush? Shall I?
Yeah, go for it. Sorry.
Cool. Okay, so we're going to do this whole thing like case-based, SBA-based. So this is first one. So you're an F1 working in ED in like a post-COVID time. A 54-year-old man comes in with severe abdominal pain radiating to the back. And when you arrive, he doesn't respond to voice or pain, and you do an A2E. So this is what your A2E shows. And the question, that should be heart sounds 1 + 2, no other added ones, not exclamation marks. Sorry.
No, just really exciting.
And the question is, what is your next step in the management? So have a read and then vote on Menti.
And if you don't know the answer, as usual, just take a stab at it, because in an exam, that's what you're going to be doing. Like you might get some questions.
They can't join the Menti.
Can't join the Menti. Yeah, are you talking about the Menti, or are you talking about the call? Because she's not actually in the call.
Oh, I see.
Right.
Fab. Okay, has everyone had a chance to vote?
Let's give it another minute.
Okay.
Well, not a minute, but a few more seconds.
Okay. Anush, what are the results?
So the majority of people have gone for option 4, which is 500 mils of sodium chloride in a 16 gauge cannula over 15 minutes.
Yep, and that is the correct answer. Okay, so let's quickly talk about fluid resuscitation. So fluid resuscitation is when you give fluids in anyone who is acutely hypotensive, because you need to replace any fluid lost from their circulating volume. So if someone is hypotensive, other than a low blood pressure, what other signs and symptoms might they have?
You can talk, or you can just put it in the chat. It's up to you, whatever you're comfortable with.
Yeah, yep. Long capillary refill, definitely. What's a normal capillary refill? Less than 2, good. Tachycardic, definitely. So if they haven't got enough fluid to maintain their blood pressure, then to compensate, the heart pumps faster. Anything else? Okay, so I had stuff like peripheries, which are cold to touch. They might have. Okay, so the key thing to remember with fluid resuscitation is you give them boluses of fluid. So that means like you give them some fluid and then reevaluate, has their blood pressure come up? No, then you give them another bolus. And a fluid bolus, standard, like the standard one, is 500 mils of sodium chloride over 50. If someone's really unwell, you can give them 4 fluid boluses, so you can give them up to 2 liters. And if that doesn't work, that's when you go and get help. Kind of like a practical tip, if you are ever in that situation, get help after the 3rd bag, because by the time the 4th one's going in, the person might not be, like, they might be on their way, basically. So get help earlier rather than later. And the limit is 2 liters.
God, I can't remember what the answer to this is actually.
Okay, so it's basically to do pressures. And it really helps you when you're reading a stem about A to E, because if you know that the person's blood pressure is physically dropped, then they're class 3, they've lost at least 1.5 liters. If you know that actually they're just slightly tachycardic, but their blood pressure's fine, they could still be bleeding. So this really helped me in working out like what might be happening to someone. But essentially, if you've given them 2 liters of fluid and their blood pressure is not improving, they're sitting in class 4 and they've lost at least 40% of their circulating volume. So your priority at that point is oxygenation as well. You need to start replacing blood products, not just like the volume of fluid, because eventually they're going to struggle to oxygenate as well. So in some conditions, you'd actually reduce your fluid bolus to 250 mils. Does anyone have any idea when you would do that?
There are multiple correct answers.
Yep, heart failure, definitely. Renal impairment, yep. So you guys have got the 2 big 4th-year ones. If they're at all sensitive to being fluidly overloaded, so heart, then you shouldn't give them 500 mils in one go. If they're a child and if they're already acidotic with a raised chloride, you want to be careful how much sodium chloride you give them and get hyperchloremic acidosis. Does anyone know what a really quick way to check someone's chloride is clinically? EBG, exactly, good. Okay, so that's basically all you need to know about fluid resuscitation. But the key thing to remember is that it's only a temporary measure, and eventually you need to work out what's causing them to be hypotensive and fix that. Why is it a temporary measure? Does anyone know? Apart from the oxygenation that I mentioned earlier. It's basically because your sodium chloride will distribute between your intravascular fluid. It doesn't just stay in your intravascular space. So after a while, you're going to lose that sodium chloride into your extracellular fluid as well. So you can't bank on it to be thing brings them back. And in terms of the cannulas, I've just put this table up. Again, don't memorize it, but just remember that the pink one, the 20 gauge, is the standard one for an adult. Anything smaller than that, the blue is more for pediatrics. And the orange and grey are the massive ones. So you'll see them used in anaesthetics. So if you're ever dealing with someone who's acutely unwell, aim for a pink if you can. And anything bigger than that is just an added bonus.
Yeah, I should point out that like ideally, so in an OSCE you'll say you want wide bore cannula, and wide bore refers to 16, but like in real life, as Preena said, like a pink is great. Anything more than a pink is a bonus.
Also, if you think about the flow rate of a pink, it's 60 mils a minute. Round that down to 50. That still gives you 10 minutes to get your whole bag in. So you're doing okay with a pink one.
That's a good way of thinking about it.
Okay, so our case continues. So he's a 50-year-old with severe, that should be abdominal pain radiating to the back, and he's seen by the vascular surgeons. So just to get everyone on the same page, what is this person's diagnosis? Severe abdominal pain radiating to the back and hypotensive.
You might not know, but just have a think about the anatomy and what can be, yeah.
Perfect. So he's got a ruptured abdominal aortic aneurysm. Yep. So this is his past medical history. He's got hypertension, COPD, a hiatus hernia, and a raised BMI. His drugs include ramipril for the hypertension, salbutamol for the COPD, and the omeprazole for his hiatus hernia. So which of the following are your most important set of investigations pre-surgery for him? It'll be on Menti, the voting.
Yeah. Also, after we've done this question, can we just go back to the previous SBA and we can just go through why some of the answers are wrong? Because I think it might be quite useful, because the first question is really, really good and important. I'll post the Menti code again for the people that have joined. So go to menti.com and enter that and you can answer.
Anush, tell me whenever you're ready.
Yeah. I'll tell you when we've got a good number of answers. Yeah. So there's a bit of a split between.
Ooh.
So like most of the people have gone for the first two.
Okay.
More for the second.
Okay, fine. So let's look at the answer and then we'll go back to the first question. So the answer is number 2. I can see why some of you have gone for number 1, and the only reason I've put it there is because it's really easy to just think everyone gets FBC, Usinase, CRP, NFT, but like nothing here suggests that he's got an infection, and nothing here suggests that anything's actually wrong with his liver. So you don't think everyone gets those. Think, what do I need about this person and what blood test will get me that? So if we go through it, you want an FBC because he is bleeding and you need to know his HB. You want some Usinase because 1, you're going to give him some drugs, so you know to know his renal function, and 2, because a AAA sometimes can involve the renal arteries, so you want to check that they're not affected. An ECG because he's got hypertension as a risk factor. So anyone who has any cardiovascular disease before any surgery should have an ECG. And then the group and cross match was so basically just testing whether you knew the difference between a group and save and a group and cross match. So with a group and save, the first thing to know is both of them, a group and save and a cross match, take 40 minutes separately. And you've got to do a group and save before you get a group and cross match. So if you do a group and save, what that does is they work out the person's blood type and whether they have any antibodies or not. And they then just keep it. They just save it in a fridge for 2 days, but they don't actually like issue any donor blood. So you do it if you know you might need to do a cross match, but you're not expecting this person to need any blood. A cross match is the next step. So they've got the donor's blood and they've mixed it with the recent group and save. They've checked that it doesn't react, and then they've issued that donor blood in however many units you've asked for, so 2, 4, 8, whatever, and it's literally sitting in the fridge ready to go. So you do a cross match if you're expecting any blood loss, and in this case you are, like, he's already bleeding and he's got AAA, so that's why the cross match was the right answer, not the group and save. I'm just going to go back to the first question, Anush. Do you want to talk over the answers?
Yeah, so I just think it's quite useful because a couple of people went for options 2 and 3.
Okay.
So I think option 1 is a pretty small bolus in someone without like any contraindications to like a 500 ml bolus. Also, like a 20G cannula isn't optimal, and over 5 minutes is I guess you could do 250 over 5 minutes, but it's not really the optimal resuscitation in a 54-year-old adult with no other history. But none of you went for that, which was great. 2 is a good option, but over 5 minutes, 500 mils, that's a pretty fast rate at which you're giving that fluid. So you need to give it over a longer period of time. 3 is a very good option, but this is something to just be aware of. Hartmann's is more physiological than normal saline, so it's really good for maintenance fluids. It's way less unpleasant, but in an acute resuscitation situation, you always go with normal saline rather than Hartmann's. And then option 5 is a very good option for maintenance fluids, but not so much for resuscitation, because 1 hour is quite slow. But yeah, the important learning point from this question is, given the choice between Hartmann's and saline in an acute emergency where you need to resuscitate someone, you always go normal saline.
Cool. Okay, so we've done our investigations. Okay, so your patient's arrived in the anaesthetics room. He's been consented for an EVAR. Someone tell me what EVAR stands for in the chat. Okay, I'm going to presume no one's typing. But it basically stands for endovascular aortic repair. So it's the operation they do for AAA. So he tells you, your consultant tells you that he would like you to deal with the airway. And I put his past medical history and his drug history there just in case. Which of the following is the most appropriate airway for him?
Bonus marks if you can tell me whether this is the most optimal operation for this patient.
Oh, Anush, you've put the answers on the Menti.
Oh, have I?
Yeah.
I didn't realize.
That's okay.
Hide results. Oh, you guys knew the things. RSI is rapid sequence induction. I assume everyone saw the answer, so I guess you might. It might be best to go through it.
Okay, so the answer in this case was he needs an endotracheal tube via rapid sequence induction because he's having emergency surgery. So what I'm going to do is I put the reasons why the others are wrong on here, but actually I'm going to talk about the airway stuff first and we'll come back to the answer for this. So what are the two main types of airways that you know for anaesthetic patients?
Well, categories of airway, I think, would be a better way to describe it.
Yeah, perfect. Yeah. So there's adjuncts which sit above your glottis, and there's an artificial airway which sits below your glottis. And then there's also, like, on the side, this whole head tilt, chin lift maneuver. When would you use a jaw thrust instead of a head tilt, chin lift? Exactly, yeah. So if you suspect that they've got not specifically a cervical spine injury, you do a jaw thrust instead of the head tilt, because that could make the injury worse. Okay, so let's talk about our supraglottic airways first. What is this called? So this isn't a Goodell, this is an NP airway. Yep, it stands for nasopharyngeal. And you don't use it if they have a base of skull fracture, because there's a risk that actually as you go up the nose, it can go, like, instead of the pharynx, up the brain. And what are the two signs for a basal skull fracture?
I'll find some images.
This is a bit more ENT than it is anesthetics. Raccoon eyes. I think it's more panda eyes, actually, yeah, and ear breathing, exactly. So if you look inside their ears and they've got blood behind the eardrum or blood coming out, I guess, or really bruised eyes, Anusha's going to send some photos. That's a sign of a basal skull fracture, so don't put these in these patients. Okay, this is a Goodell. And does anyone know, with the nasopharyngeal and the Goodell's, how you measure the size that you need to give your patient?
Also, I think it can be panda or raccoon. It's just like American versus English.
Right.
Fine. I think we go for, I can't remember what we do here.
Good, yeah. Angle of jaw to chin. You're close, not quite. So one of the really easy ways that I remember this is, like, when you look at a Goodell in real life, it's plastic, it's quite hard. So with a Goodell, you go from the hard to hard. So you'll go from your teeth, your incisor, to the angle of your jaw. With the nasopharyngeal, it's more rubber, it's like soft. So you go from the soft tip of your nose to the tragus of your ear, which is also soft. And generally a green Goodell is the right size for an adult. Okay, what is this airway adjunct called? Okay. So this is called a laryngeal mask airway. Good, Jess. Yeah. It's called an LMA sometimes as well. And the key difference between this one and the other two is that it's got this weird round thing at the end. So you can basically connect it to a ventilator. So you don't have to manually bag this patient. You can paralyze them. So the key points about the adjuncts are that you can manually bag anyone with any of these in, but none of them actually protect against aspiration. They all sit above the glottis. Okay, which leads nicely onto our infraglottic airway. What is another word for the infraglottic artificial airway? I kind of gave it away in the SBA. What's it called? Yeah, exactly. This is an ET tube. It looks like this, and it sits like this. So it goes through the person's mouth, past the glottis, and in between the vocal cords, and then there's a cuff that holds it in place. If you can see it go in and ask if you can have a go. I got to do one. It was loads of fun. And the main difference between this one is that if anything tries to come up the esophagus, it gets trapped above the balloon, so it stops against any aspiration. Which leads on to my next question. When would you possibly want to do it in someone? I.e., what things can you think of that increase the risk of someone aspirating? Yep, if they've got reflux disease, good. If they're having open surgery, yep. If they've not been nilled by mouth and recently eaten, yes, good. Okay, so these are the ones that we had. So if they're having emergency surgery and they might have a full stomach, you do this. If they've got a hiatus hernia, they're more likely to reflux. If they've got a high BMI, they've got probably more abdominal pressure shoving on their diaphragm. Same with laparoscopic surgery, when they put CO2 to blow up the abdomen, it pushes on the diaphragm a bit more. Any open abdominal surgery, if they're pregnant, if they're ever going to do a surgery where they're head down, then it makes them more likely to aspirate. And remember that this isn't just like aspiration risk when you're intubating them, but aspiration risk throughout the operation. Okay. I forgot to take that out. Anush, do you have any others you want to
add? No. Advanced pregnancy is actually very important, but don't worry about it because it's in 5th year. But there's like an important syndrome you'll learn about for your own learning, Preena.
Thanks. Okay, so we've done the 2 types of airway, and now the other one is how you actually put the airway in. So for those of you who've been in theatre, generally just put in the chat what kind of things do they do before they intubate someone.
Just like what you've seen if you've been to theatre. If not, don't worry.
Yeah, they give them oxygen. Good. Do they do it when they're awake, asleep? Okay, so what they do is they sometimes asleep. Good, yeah. Thanks for answering that. So sometimes they pre-oxygenate the patient, and we'll come back to the idea of pre-oxygenating. And then they put them to sleep. So they titrate the anaesthetics. So basically, they'll give them some propofol, and then they'll be like, John, can you open your eyes for me? And John can't open his eyes, and that means he's got enough propofol. He's asleep. And if they've given him a paralyzing agent, then maybe they'll bag him to make sure he keeps breathing. And then they put the airway adjunct in, and sometimes they connect it to a ventilator if they're not breathing for themselves. Otherwise, they just let the patient breathe. And that's the standard way of doing it. Rapid sequence induction is slightly different. Does anyone know how it's different?
I didn't know this until like a week before exams. Lol.
If I was to tell you that you use rapid sequence induction for emergency cases, especially in cases where they haven't been nil by mouth, bring any ideas to you guys? Okay, so in rapid sequence induction, you pre-oxygenate them for longer, and I'll ask you what, we'll come back to why. And then you give them some really quick acting drugs, so you don't titrate the propofol, you just send them to sleep and give them a paralyzing agent. I wouldn't say these doses, but know that you give them like a muscle paralyzing agent and a anesthetic. And then you don't bag them at all. And then you just intubate them with some cricoid pressure. Does anyone know why we do any of those things? I can appreciate that if you guys don't know, or this is the first you're hearing about rapid sequence induction, you probably don't, but do you guys want to guess why you don't bag them? Cricoid pressure might be why you pre-oxygenate them for longer.
Probably go through it because I don't think you can figure it out. It's kind of it's one of those things you either know or you don't, right?
Yeah, it's intuitive when you work it out. Okay, so let's start with the first one, oxygenation. So you and I, it comes back, I hate to take it back to first year, this graph. Okay, so when you and I exhale, the volume that's left is our residual volume. And right now we're breathing room air. So in our residual volume, we've only got 21% oxygen. So if we both, like if we stop breathing right now, all our body has is the 21% oxygen in our residual volume to use up, and then our sats drop. And that's why it happens really quickly if someone does stop breathing. But if you know that you're going to need some time between sending this person to sleep and actually get airway in them, then the way you buy yourself time is making sure that 100% of their residual volume is oxygen. Because then instead of 21%, you've got 100%. That's like almost 5 times as much. Someone put a yes or no in the chat, please. Okay, well, I'm going to move on. Okay, so you've pre-oxygenated them. You've given yourself enough time to intubate them. And then you get to the bit where you paralyze them, they're not breathing. And the intuitive thing would be like, they can't move their muscles, I'll bag them. But the reason why you don't bag someone who is not yet intubated is because when you bag, you're pushing air not only through into their lungs, but also into their stomach. So if this person's already high risk of aspiration, you bagging them is going to shove more air into their stomach and get it gurgling around, and you're actually increasing their aspiration risk. So actually, you don't bag them, you just get on with intubating them. And the way they intubate it is as normal, but they use this thing called cricoid pressure. So your anaesthetics assistant, be it the junior, the ODP, whoever, they will physically be pushing down on the patient's cricoid, and it will just be compressing their esophagus. So it means that anything that does reflux is less likely to come up during the process of intubating. Okay, any questions about any of that?
That's like pretty like I think like a lot of that's quite conceptually like challenging. So like don't worry if you don't get it. Like just go over it. Like just have a quick glance over it. Like I think Wikipedia like has some pretty easy to read stuff about it. Just have a look over it, or have a look over these slides again, and like you'll get it eventually.
Yeah, and
it's definitely not like a listen once, remember thing. I think Preena would agree.
Yeah, and also once you've seen it, it makes sense. And if you, I forgot what I was going to say. Yeah, once you've seen it, it makes sense. And once you do understand it, you never really forget what happens because you can work it out. So this would be one of those things where I'd say understand, don't memorize.
I think it's also just worth, like, hopefully you get to see some anesthetics. It's like super hands-on, like they really get you involved. Like you'll get to put these airways in. They might even like teach you how to intubate. Like it's probably the most like interaction you'll get in like your entire fourth year.
Yeah.
So hopefully you do get an opportunity. And yeah, once you see stuff like this, it does tend to stick in your head because like you're so involved in the entire thing.
Also, everyone's really nice. I've never met an unfriendly anaesthetist.
Yeah, they don't really exist. They're generally the nicest specialty.
Okay, so whilst we've got this in our head, let's just quickly go back to the SBA. Okay, so the question was, which of the following is the most appropriate airway for this gentleman? So first things first, he will be having an ET tube. He's not been nil by mouth, and he has quite a significant aspiration risk. He's got a hiatus hernia, he's got a raised BMI, so you need to protect his airway, and the best way to do that in this case would be an ET tube. And then you need to think, can I intubate him as normal, or do I need to do rapid sequence induction? And the thing that gives it away in this case is the fact that it's emergency surgery. So he's not been nil by mouth. So you do need that pressure. You can't bag him because whatever is in his stomach will come up as you bag him. So you've got to do rapid sequence induction. So that rules out option 2 and 3. And the reason why you're doing rapid sequence induction on him is not because he's having open, because EVAR is not open, it's endovascular aortic repair. And it's not because he's got hypertension, it's because he has not been nil by mouth and it's an emergency situation. Does that make sense to people? Hopefully it does. You can, yeah, good. Okay. Okay, so I think that's all from me, Anush. Do you want to take over?
Yeah, so we'll talk a bit about elective surgery, and like it's a bit less exciting than all the emergency stuff. But I would argue that I think it comes up a bit more in exams because there's quite a bit of overlap with some other specialties. So like I've tried to tie in, there's a little bit of cardiology, there's a little bit of endocrinology, there's a little bit of weird stuff. The only thing I want to add to Preena's slides is when you get a chance, go through like the mechanisms of some of these anesthetic agents like succinylcholine. That's like a mechanism that could come up. Like pharmacology is like not as like prevalent in fourth year as it is in like second year, but it's still like quite important.
If you can, just like refresh the whole antimuscarinic, muscarinic.
Yeah, I would say it's worth doing. So this is the real question you need to ask yourselves, like in terms of elective surgery. So before people have an elective surgery, they'll have like a pre-op appointment, perhaps like 2 weeks before, maybe more, where this is the kind of stuff an anaesthetist might discuss, or it might be the surgeon. It kind of depends on the hospital. But what kind of drugs do you think we want to stop before surgery? Like don't worry about any guidelines and stuff. We'll talk about those in a minute. But just from common sense, what kind of things do you want to stop before a patient is going to be cut open? Absolutely, anticoagulants. You don't want the patient to bleed out on the table. Yeah. What else? So what else can go wrong? So ACE inhibitors, very important. So my question to you is, why do we need to stop ACE inhibitors? If you've done renal or have revised renal recently, you might be able to figure this out. Yeah, absolutely. So we'll go over it in a minute, but The issue is ACE inhibitors. It's a mix of things. You already have hypoperfusion of the kidneys during surgery. If you continue them on an ACE inhibitor, they're more likely to get like a post-op AKI. Can cause hypotension. It basically messes with the renin-angiotensin system. Yeah. So ACE inhibitors, anticoagulants. Okay, what else? Yeah, contraceptive pill. Yeah, definitely. Any idea why? It's more of a post-op complimation thing. Yeah, exactly. Your increased risk of DVTs and clots. Yes, that's exactly why. Good. So yeah, those are like the big groups. So good. So here is a good mnemonic. I don't really like mnemonics, but I'm sure some of you do. So I is insulin. We'll talk about so insulin's a bit weird. Lithium. So what do we use lithium for? It's not really a fourth year thing, but you should. It's good to have an awareness. Bipolar disorder, yeah, absolutely. Anticoagulants, as you said. Think of like the hormonal things together. So the combined oral contraceptive or hormone replacement therapy, both of these need to stop. K is for potassium-sparing diuretics, because yet again, they interfere with the RAS system. O is oral hypoglycemics. So what kind of oral hypoglycemic agents can you think of off the top of your head? Yeah, so metformin is involved in this acronym. So you do tend to change how you give metformin before surgery, but technically it's not a hypoglycemic. It simply increases insulin sensitivity in the body. So it's not a classic hypoglycemic, but yeah, it is involved in this list definitely. Sulfonylureas are like your classic oral hypoglycemic. But yeah, good. And then P is perindopril or ACE inhibitors. That one's annoying because who the hell remembers perindopril? It's not like the most commonly prescribed ACE inhibitors. Right. So I think we'll do the simple stuff first. Combined oral contraceptive or hormone replacement therapy. Do you think this will take? Do you think this stuff will take a long time to have an effect or a short time to have an effect if it's hormonal? If it's based on the endocrine systems. So basically, if it takes a long time, you'll have to stop it earlier. So do you think you need to stop this early or late? Longish, yeah, absolutely. So you need to stop these 4 weeks beforehand, which is actually like a really long time. Lithium. There's no way of really figuring this one out, but you stop it the day before. If you were going to forget one thing, you can forget lithium. It's the least likely to come up. ACE inhibitors, ARBs, and potassium-sparing diuretics. Any ideas when you stop these? So how quickly do these work? If you're worried about hypotension. So you stop these on the day of the surgery because remember, these work on channels in the kidney. So like you take the drug, they get to the kidney pretty quickly. You'll get an effect fairly quickly. So you stop these on the day. And then the weird stuff is insulin, oral hypoglycemics, and anticoagulation. Right. So we'll focus on insulin and anticoagulation because those are really important. Oral hypoglycemics, I've put a slide with like a screenshot of the guidance, and I'm not going to go through it because honestly, I'd be doing you a disservice because it's not super likely to come up, and like there's not really a simple way of explaining it. So anticoagulation. What are like the three big reasons to anticoagulate someone? So this is some cardiology. So those of you who've done some, or if you haven't done some, you'll learn some cardiology. Metallic heart valves. Yeah. Atrial fibrillation. Yeah. One other thing. Stents is a very good point. I haven't put stents, but yeah, depending on the stent, you would consider anticoagulation. Yeah, so recurrent thrombus, thrombi, PE, DVT, that kind of thing you would anticoagulate for as well. So I would, yeah, so stents are also important. Certain stents may need anticoagulation, certain may not. So
just to add something, sorry.
yeah.
The key thing with elective surgery is that it's elective and you take every step you can to optimize the patient before they have their surgery. So if someone is anticoagulated and there is an end date, i.e. they've just had one DVT after being on a flight and they just need to finish their anticoagulation, you don't do the surgery until they've finished. So basically, if you can, you delay the surgery as much as you can till you've solved the problem.
That's a very good point, actually. So
as a general
principle. Yeah, so if you have like a one-off like DVT and you're on like 3 months or 6 months of anticoagulation and the surgery can wait, you're just gonna wait. Because it's just lower risk. What are the two scoring systems that we use to decide, especially with atrial fibrillation, whether or not we anticoagulate someone? Unfortunately, you do need to know at least one of these in detail. It's one of those annoying things that comes up. You shouldn't. So Chad's VASC 2, Chad's 2 VASC. Yeah, so that's the risk of what? A Hasbled, yeah. So you do both of these scores and you basically look at how highly they score on each and you're like, oh, is it worth the risk or is it not worth the risk? I'm not going to ask you to go through the components of Chad's VASC, but like have a read. I think it's good to have an idea of the things that make up Chad's VASC. So what are the options for anticoagulation? So we can split them up into long-term and short-term. So, whoops, I gave away one of them. So in terms of short-term anticoagulation, what are the options?
As in drugs that you could use which are short-acting anticoagulants.
Yeah, not necessarily short-acting, but yeah, so if someone only needed anticoagulation for like a few weeks or something like that, what drugs could you use? Low molecular weight heparin is absolutely one. Yeah. What's the other option? So you might have seen this if you've had a renal placement, because renal patients cannot have low molecular weight heparin. Well, end-stage renal failure patients can't have low molecular weight heparin. You can also use a DOAC in the short term. DOACs are amazing. Warfarin we don't tend to use short term. We tend to use long term, and we can talk about that in a minute. So the other thing, so this is almost exclusively used in end-stage renal failure, unfractionated heparin. So what's the mechanism by which you give a patient low molecular weight heparin? Do you give it as a tablet? Do you give it as an injection? Do you give it as an infusion? Yeah, subcut. You give it subcut. It has a pretty good half-life, so you give it like once a day. Unfractionated heparin, very short half-life. You give it IV as an infusion, and you almost exclusively use it in end-stage renal failure. You don't need to know much about unfractionated heparin. It's just one of those weird drugs. Long term, so you've already said warfarin, or you can use a DOAC. You can use a DOAC now in the short term as well. So back when I did year 4, if you had a PE, you would treat that with low molecular weight heparin. Now, if you have a PE, the guidance has changed. You can just treat it with like a DOAC immediately. So you can use it in the short term as well. So these slides need updating. So can anyone tell me why we don't use warfarin in the short term? There's some clues in terms of wait, there's no clues on the slide, but you may know this. Is it easy to simply start warfarin? Like, can you just take warfarin and then go off? Yeah, so it needs titrating, and it can take weeks or like months to like titrate. And yeah, it's initially prothrombotic. Yeah, that's really good. I didn't know that until quite late in the year. So both of those things mean that it's not so great in the short term. It's good in the long term, not so much in the short term. Obviously, there's issues with using it long term, especially interactions. And it all goes through like the P450 system, and you've probably know there's some acronyms you can memorize about that. What does that mean? So prothrombotic means.
So basically,
I've got a slide on it in a minute, so we'll talk about it. So we'll come back to that, Davina, in just a second. So when you're stopping anticoagulation before surgery, yeah, this is why you need to do it. Patients will bleed out otherwise. Warfarin, DOAC, low molecular weight heparin. Oh, wow, I got it the wrong way around. Warfarin, you stop it 5 days before the procedure. And if they're high risk for getting clots, you bridge them with low molecular weight heparin, which has a far shorter half-life. So you stop the warfarin. If they're low risk, you don't need to anticoagulate them until the operation. If they're high risk, you can give them low molecular weight heparin. DOACs, they have a shorter half-life than warfarin, but it's still like a bit iffy. So you tend to stop 3 to 5 days before the procedure. The exact time you stop depends on multiple factors. They won't really ask you about this, so don't worry about it. You just need to know that you do stop them a few days beforehand. Low molecular weight heparin, so it lasts around a day in your bloodstream, so you can stop it. So the half-life is around 12 hours, so you can stop it 6 to 12 hours before surgery. And it's important that you start it a few hours after the surgery again, because what is like a very common post-operative complication if in immobile patients? Yeah, so DVT, which may cause a PE. Exactly. So we talked about, so when you start warfarin, what else do you start for the first few days and why? So we've mentioned prothrombotic, and I'll explain exactly what that means in a minute. But what do you start for the first few days of warfarin therapy? Yeah, so you bridge them with a low molecular weight heparin. So they're going to be taking both the warfarin tablets, and they're also going to be getting their subcutaneous low molecular weight heparin injections. And the reason for this, does anyone know why it's prothrombotic? So prothrombotic means, so the whole point of warfarin is it prevents you from clotting. But in the first few days of starting warfarin, you are more likely to get clots than without warfarin. Does anyone know why? This is some fairly interesting physiology, actually. Preena, this is such like a classic consultant question, isn't it?
This is one of those, like, once you've understood it, you won't forget this fact about warfarin.
Yeah.
And
it is wild. It's wild. So the reason for is, so you start low molecular weight heparin as bridging therapy because warfarin works by preventing the synthesis of these vitamin K dependent clotting factors. Does anyone remember what those are? God, that's a throwback to first year. Anyone remember? This is a rare example of FHMP being a useful module. Any ideas? Or like, is there a mnemonic that you could use to remember them? Preena, do you remember them?
yeah, but I don't have a mnemonic.
So it's 2, 7, 9, and 10. So it's not quite intrinsic versus extrinsic, but it tends to be more of the intrinsic ones. But yeah, it's 2, 7, 9, and 10. You can use 1972 as the one that like a lot of people use. Yeah, 2, 7, 9, and 10. But the thing that they didn't really teach you about in first year is the fact that proteins C and S, which don't really form like a part of the clotting cascade, are also vitamin K dependent. and these have a shorter half-life. Protein C and S are proteins that prevent clots. Thus, if you can't produce these and they have a shorter half-life, which means you run out of them more quickly, you're initially more likely to clot. So you lose protein C and S first. Protein C and S protect you against clots. So if you just start a patient on warfarin, they might have a DVT or a PE initially. It's really strange, and it's quite important that you bridge them with low molecular weight heparin. If that doesn't make sense, let me know, and I will try and find out another way of explaining it. But it's a bit wild, as Davina said.
If anyone doesn't like 1972, I use like +7 is 9, and then 10 comes after 9, basically. I don't know how, but that's just how I remember it.
You'll all find your own ways of remembering these things, ultimately. Whatever sticks, right? Yeah, fab. Okay, so this is the last thing. We're going to end on this because it's almost been an hour, and you guys need to get dinner. Insulin and surgery. So what's the problem with continuing normal, like general insulin during like long operations, or just operations in generally? There's two problems with this in terms of the physiology of continuing insulin. So what kind of things can you think of? Again, try and pretend you don't know any medicine for one of them.
Can patients eat during surgery?
That was the one I was hinting at. Yeah. So patients might not be eating anything is problem number one. Problem number two, you do need it is a bit medicine-y in that, yeah. So if patients not eating anything, they can get hypoglycemic episodes. Problem number two, surgery is a stressing experience. Like it is actively stressful on the body, which means surgery will cause you to produce cortisol, which means there is some insulin resistance. So you may need to change the dose of insulin as well. So like it's like these two things you need to balance. So you can think about it in terms of minor procedures where patients have good glycemic control, or you can think about it as major procedures or minor procedures with poor glycemic control. So if someone has bad glycemic control, you're going to manage them as a major procedure regardless. If it's a minor procedure and the patient is like really on top of their insulin management, you can sometimes just adjust their regimen. You can change a few things here and there. I wouldn't worry too much about that. That's not the bit that they can examine you on, because I don't know the answer. You probably just ask an endocrinologist to have some input. Major procedures is what they can ask you about. So the day before, you're going to reduce their insulin dose to 80% of the long-acting. On the day of the procedure, you're going to continue at that reduced 80% dose. And then after the operation, you continue the long-acting at the full dose, but you also have a sliding scale infusion in order to manage how well they're eating or drinking. So sliding scale insulin just means you regularly check their blood glucose and you make adjustments to the insulin infusion every time you check the blood glucose. You don't need to know much more than that. So the big thing to take away is short-acting insulin, you pretty much stop. Long-acting insulin, you continue. And like generally, this is a rule for lots of medicines. So if a patient has diabetic ketoacidosis, you're going to continue long-acting insulin, and you're going to manage their ketoacidosis by using an infusion. So whenever in doubt, keep the long-acting, stop the short-acting, but ultimately you will get endocrinology to have some input on these patients. Does that make sense? If not, let me know. So this is another thing I didn't know until this year, and I think it's quite good to know. When exactly do you switch a patient's IV insulin infusion to a subcut infusion, and why? So patient is post-op, they've had their IV insulin infusion. When are you going to be ready to switch them to subcut? And then when exactly do you make the switch over? So we're talking about short-acting insulin rather than long-acting insulin now, because the long-acting is going to have continued, because it's like their physiological insulin. Absolutely. So when they can tolerate eating meals again without nausea and their appetite returns to normal, that's when you're going to consider switching them to eating and drinking. And this is the bit I didn't know. So you're going to give them their first dose of short-acting insulin, and then you're going to wait 30 to 60 minutes before stopping the IV infusion. And the reason for this is insulin has a very, very, very short half-life when given IV. I think it'll stop in like 2 minutes. So if you stop the IV insulin, they'll immediately start going into DKA or HHS. So you have to wait 30 to 60 minutes after you've given them their first hit of their short-acting insulin. Hopefully that makes sense as well. These are the oral hypoglycemics. You can read these in your own time. They're kind of weird. I think that they're less likely to come up, but it's probably worth reading over once. And that's the anesthetics we're going to do for today. We'll try and do some more ATE assessment stuff going through. Like we've got loads of cases and stuff planned over the course of like the term. So we'll try and do more ATE assessments because they're useful. We'll do some stuff on pain management at some point because again, it's like pretty like common in exams. The other thing, like I haven't figured out how we're going to do yet, but like we need to do maintenance fluid prescribing because I think it's taught pretty poorly at med school. I think Preena would agree.
Yeah, I'll do that one day for you guys.
Yeah,
Also,
so we'll try and sort that out as well. But yeah, if there's other stuff you want, I'll just send you the feedback form. Just like let us know.
Just a note about the diabetes and insulin stuff. For elective surgery, most patients are going to be like nil by mouth for a long period of time as well. So sometimes actually you admit them the night before, or during the operation, you give them some fluid as well. Does anyone know specifically what the type of fluid you give them is called?
Good question.
So it's called 5% dextrose, exactly. And that's pretty much the only fluid that has sugar in it. So it's used either when you give someone infant fluids, which I'll do a session on sometime in the future, or when they're diabetic, because obviously you're giving these people insulin, but other than the stress environment and the cortisol, you also need to make sure you don't cause them to have a hypo.
Yeah, definitely. It's challenging. I think people underestimate how challenging diabetes as a disorder is generally. Like it's very complicated, to say the least. Here is the feedback form. If it pastes, please work. Any questions about anything we've done today? I think that was quite heavy. So yeah, have a read. If you have any questions, yeah, just message any of us and we'll get back to you.